Oh, brilliant. Lovely. Thank you very much for those of you who've joined us this morning. It's good to have this session with us this morning, this Tuesday morning. My name is Ruth Jones. I'm the Member of Parliament for Newport West in South Wales. In my previous life, I was a physiotherapist, so I have some knowledge of the subject. And also in my current role, I am the Shadow Minister for Waste and Recycling, which includes plastics. So obviously the equipment used in the urology sector is part of that. So it's really good to learn from the experts that we have with us today. So what we're going to do first is oh yes, I should also mention that I'm also a member of the all-party parliamentary group for bladder and bowel continence care, which is a bit of a mouthful, but it's a very useful group to actually share look at what's going on across the UK, if you like. So it's really useful from that point of view. Obviously, we have the experts. Don't rely on members of parliament to provide the expertise. We have people who can do that much better than us. I can start off with obviously that's my introduction. What I would ask the attendees is if you could keep your yourselves on mute, please, and then put any questions you may have in the chat function, and we will pick those up at the end. What we're going to do today is run it as a questions, if you like, questions for the experts, and what we will do is make sure that everybody has a chance to ask their questions. Don't worry, nobody will be leaving here with unanswered questions. So what I'm going to do is go over first and ask our panelists to introduce themselves. So I'm going to start off with Clare Waymont, please.
Good morning and thanks, Ruth. My name's Clare Waymont. I am a urology advanced nurse practitioner working in Royal Wolverhampton hospitals. I've been a qualified nurse for 32 years now, and 21 years of that has been working in urology. I am also the current president of the British Association of Urological Nurses, or BORN, and our our aim through BORN is to support the development and education of urological nurses, ultimately to improve patient outcomes and patient care, and to collaborate with other organisations to that end as well. Thank you.
Brilliant. Thank you very much, Clare, and it's lovely to have you here. And I should say that Clare has stepped in at rather late notice, so we're very grateful to you, Clare. Thank you very much for that. I'm going to move on to Louise, please, next.
Good morning. Thank you, Ruth. Well, I'm the Chief Executive of the Urology Foundation, and we are a charity that funds research into all aspects of urological cancers and diseases, including conditions such as urinary incontinence. And we also fund training and development of urology professionals. And our mission is to improve survival and improve quality of life as well for urology patients. Our website provides patient information, and we run and promote Urology Awareness Month, which takes place every September and is happening at the minute.
Brilliant. So we are very aware, which is great, which is why we're having the session today. So thank you very much, Louise, for that. And I'm going to move on to Hannah, please.
Hi, good morning. Thank you very much for having us. Thanks for staying with the experts. I'm not sure about that, but we're going to try and do our best, Ruth. So my name is Hannah Gagen. I'm the Head of Government Affairs and Patient Advocacy for Coloplast. You'll have to forgive me a little bit. I'm still, I think, at the end of my second month, so I'm coming to Coloplast with a pair of fresh eyes. But essentially, Coloplast is we're a Danish company with head offices in Peterborough. We develop products and services to make basically life easier for people living with what I would say are probably quite deeply personal and private medical conditions. So I don't ever mind sharing, but so I have an ileostomy. I use a lot of these products that basically mean that I can just crack on every day getting stuff done. So I kind of understand it from that very personal perspective as well. But I do know for lots of people, the conditions they have are, can be associated with trauma, sometimes quite taboo. Nobody really wants to talk about wee and poo and stuff like that, but you kind of, that's what we are experts in talking about that to make things easier. And I think that the more the intimate the kind of health condition, the greater requirement it is for us to understand their well-developed solutions that are sensitive to their needs, really. So this is kind of what we call intimate healthcare, and that's why we're here today.
That's brilliant. Thank you, Hannah, ever so much. So as you can see, our panel, we have a cross section of views, if you like. So we have experts from all angles of the bladder and bowel care, if you like. So that's really, really helpful. So thank you very much for that, the three of you. What I'm going to do now is I'm going to move on to question one. And what we're going to do is we're looking at basically the priorities for the new health and care bill. And obviously it's very topical because that's coming through Parliament even as we speak, sort of thing. So what we'd like to do is explore what it means for people on the ground, people in the clinical settings, patients, clients, what does it mean across the UK? So what I'll do first, so that's question one, very helpful. Thank you, Imogen, it's put up on there. What are the key priorities for the health and care bill and the future of the NHS from the perspective of a clinician, a patient and a supplier? So let me go to the clinician first. Let me go to Clare first. And what do you think the key priorities are from your point of view?
Well, I mean, I think ultimately, what we hope is that this will provide some equitable access of services for patients across the board, and allow us to, this will aim our recovery from COVID. I think that's got to be one of the, the prime aspects at the moment, because that's where everybody is at the moment. And moving forward, we need to be able to achieve that, however long that's going to take. It's going to help us to improve some resilience and to provide some kind of mutual aid, spread across, our services. And also to allow us to develop and take on new technologies, and therefore patients can access that more freely, and to create more specialist hubs where that expertise can kind of develop, and ultimately that will help us to improve things like recruitment and retention of staff, and development of staff and leadership, because that's what we need within the health service to be able to drive forward and sustain the services that we have. But we're coming from a period from COVID now where everything's different, and we've got to adapt, and we have to change in line with that, and make sure that we can continue to sustain and deliver a service that's that's going to continue to improve for our patients.
Yes, I'm going to come back with some supplementary questions in a minute, but let me go to Hannah next. From your perspective, what do you see the key priorities?
So we broadly welcome the bill. Obviously, it's going through a great pace, which I know that you guys only got one weekend rather than two to look at it. So it kind of says very importantly how quickly it's going through. So I suppose that's something to kind of acknowledge, really, is that it's going through a very difficult time. It's going through quickly. It's a lot for people to understand and kind of get hold of, really. But broadly we welcome it, specifically the bits about collaboration, greater partnership, working at a local level, really important. And I think especially the bits in clause 67 around strengthening patient choice. I don't know whether you use patient, people with a condition kind of interchangeably, but I think that's really key. And then lastly, I suppose I'd probably say there are some bits that we still seek further clarification on, as it goes through and more amendments are put in. But I think some clarification and reassurances in the areas about what it might mean for people with intimate healthcare needs specifically. So, in particular, we're keen to understand how the bill might make a difference for those living with intimate healthcare needs, particularly where those conditions have historically kind of seen significant variation, I would say, across the country. So I think this bit of legislation, with the other bits coming through on levelling up, postcode lottery, I think it's a bit is like not really looking at it in silo, but making sure we're thinking about each of these bits of legislation, how they're going to fit in together. And then I suppose the other thing is just how it'll all be done by April. It's a chicken and egg thing, isn't it? Like it's got to be created, but yeah. So I think there's a lot in here for us, but I think the bits that will come up for secondary legislation and further amendments are the bit we're now keeping an eye on.
Yes, the overarching looks good, but it's when you drill down into the detail that we really need to get stuck into it. You're quite right, Anna. Louise, what are your key priorities?
Well, yeah, absolutely. I think, the shift away from the focus on competition towards the new model of collaboration and partnership has got to be a good thing for patients. I'm really pleased to see emphasis on quality improvement as well within the bill. Our charity, the Urology Foundation, has actually funded a 4-year programme called Icip, which is Education in Quality Improvement, which is designed to ensure that a continuous improvement mindset is second nature in urology professionals. Now, we've been very supported by urologists and consultants in developing this programme and getting it onto the urology curriculum, but there is still a huge mountain to climb when it comes to embedding and integrating measures into the health service at large. And I think that's the perennial challenge, isn't it? It's how do we translate and embed good intentions and pockets of good practice across the whole system. So I think, the bill will not work simply because there is a legislative change. Obviously that helps, but it requires changes to the deep-rooted behaviours and attitudes and relationships of staff and leaders right across the health and care system, and they need to be supported to make that change, make those changes and to develop those relationships. So I think this makes the implementation plan really, really important, because my understanding is that the legislation leaves quite a lot to local discretion.
Yeah, that's a good point. And you've also covered my supplementary, because obviously the bill is very clear that it's all about collaboration or cooperation. I'm a bit disappointed that it's not collaboration more strongly than cooperation, but even so, it is a step in the right direction. You're quite right, Louise. And obviously, coming from Wales, NHS, health has devolved to Wales, and within our health boards, if you like, slightly different. We've always had cooperation and collaboration between health boards, because obviously for patient care, as Hannah alluded to, it's really important that patients don't feel stuck in a silo or in a postcode lottery, and it's really important. You use the phrase levelling up. It's like, oh yeah, but you're quite right. We should be levelling up. We should be making sure that the best practice comes across the whole of England, not just pockets. And I think that could be really helpful. So yes, thank you very much for that. You've outlined that very, very clearly. So let me move on to question 2. There we are. The proposed health and care bill implements NHS England's recommendation to support integration by legislating for every part of England to be covered by an integrated care board, an ICB, an integrated care partnership, an ICP. So we love the abbreviations, don't we, in the NHS? If it's not CCG, it's ICB or ICP. Anyway, so the question now is, how will the establishment of ICBs and ICPs impact the urology sector, and in particular patients affected by urological conditions? So let's start off with Hannah and see, give me your thoughts on this then.
Sure, thank you. I mean, it's a massive question really, isn't it, this one, because this is kind of getting to the nuts and bolts of what we're talking about. But I suppose the bit that I'm really interested in is about the representation on the boards, specifically in terms of people with intimate healthcare conditions. So as I'd kind of, often with these things, those who shout the loudest will be heard. And I think, as I said, alluded to earlier, sometimes with some of the conditions that we make products for and the services, not everybody wants to talk about it and don't feel comfortable talking about it. It still feels quite taboo. So I think that there's a question in reality about how representation of people with different conditions will actually happen in the boards and in the partnerships. And I would also say the other thing is that one person, obviously, I'm always a bit wary of N equals 1. So, if I go on a board as a person with a particular experience, that's not necessarily representative of everybody with my condition, but it is a lived experience, so it's better than nothing in a sense. But also I think having a diversity in that representation will be important as well. So trying to see across all of the boards where we've got some kind of representation of the population as a whole will be key. So for me, it's that, and then also just the nuts and bolts of where the power lies, who's actually making the decisions on the ground. I think all of that will be really interesting as we move forward.
yes, it's all about that. It's the so what question, isn't it? We can have ICPs and ICBs.
Yeah.
What does it mean for the patient on the ground, sort of thing? Yes, no, you're quite right. Yeah, Louise, your thoughts?
Yeah, I mean, I think I agree with a lot of what Hannah's just said. I think it's important to understand that a lot of patients who have a urological issue, I mean, particularly in relation to something like urinary incontinence or bladder problems, are not only urology patients. I mean, many have multiple health issues such as MS, or spinal or neural injuries, or dementia, of which urinary incontinence, for example, is but one manifestation. So yes, you know, the sentiment about having the integration between health and care services is really to be applauded. The provision for data sharing, which comes within the bill and between the two kind of bodies, is also, I think, really appropriate and important for the improvement of health and service planning. And I think as a kind of concrete example, how I would like to see the two, you know, the ICBs and the ICPs working is I'd like to see these integrated bodies collecting data of how many people in their area are suffering from incontinence issues, for example, and if possible, using that data to prevent closure of public loos in their areas, which, you know, we know is a really big problem. And we believe that the number of people being treated for incontinence, you know, the numbers that are being quoted, which is something like anything between 3 to 6 million. That's the bare minimum, because we believe the reality is there could be as many as 3 times more people who are suffering who are not actually receiving medical attention. So something like the provision of sufficient public toilet facilities should be seen as a public health issue. And that's, you know, one sort of concrete example where I'd quite like to see that type of integration taking place and using the information and using the data to make those sorts of changes and recommendations. And of course, you know, there are obviously huge numbers of people in residential care homes, and many of whom suffer from incontinence or who are prone to urinary tract infections. And I'd like to see this integration extended to these care homes, because the majority of which are actually independent providers, so that there are plans for how these care home providers will work towards targets such as reducing catheter-related UTIs or ensuring that their residents are kept properly hydrated, for example.
I think that's really helpful, and I think you've hit on, there's the public aspect, public health aspect, as you say, about and just something as simple as having toilets accessible when you're out and about, so important, you know. And you know, we used to talk about the radar keys and things for people with disabilities, you know, who had to access it. You know, a public toilet is a fundamental right, surely, you know, that's one of those difficulties, which I know when I used to work with children, say with long-standing conditions or whatever, that was one of the big bugbears. Parents said there's nowhere to go to change, you know, whatever. So yeah, absolutely. Sorry, Claire, I'm wittering on here. I must stop now. Claire, please give us your perspective, what you think about ICBs and ICPs.
Yeah, well, I mean, obviously listening to Hannah and Louise, you know, it is looking at things from more of a population health, you know, needs, you know, perspective. But, you know, from my perspective in secondary care, you know, what we're hoping that we're going to be able to achieve through this is, you know, reducing the variation in health outcomes for patients by, you know, kind of addressing that inequality of services in different localities. And ultimately, that's going to mean that there's going to be greater movement of patients, because they're going to need to be able to access those specialist services to improve their patient outcomes. And, you know, picking up from what Louise was saying about urinary incontinence, you know, there are some areas that, you know, don't really have a really good established service for things like that. And, you know, if we can actually, you know, through the ICPs and obviously ultimately the ICSs, the integrated care systems, that, you know, we can kind of improve that, then that's got to be, you know, a positive for patients, because, you know, we you know, in every area, we're just not able to offer that kind of high level specialist service for all aspects of urological treatment. You know, and what we're hoping is that, you know, we will be able to, you know, streamline the pathways and create more efficient working, and to look at things like more innovative practice and more day case surgery for urology patients. And this fits in really nice with the work of the GIRFT, you know, the getting it right first time, and you know, all these kind of things being pulled together, you know, should, you know, ultimately we want to make our services better for patients. We want to be able to ensure that all patients can access, you know, this kind of specialized services that they need wherever they live. And, you know, it's going to be hard work, and it's going to be something that's not going to happen overnight. But, you know, I can see some real positives in that kind of moving forward. And, you know, things like clinical trials as well. You know, all patients need to be able to access anything, you know, that they can, rather than, you know, there's a clinical trial but it's only available in London. You know, what we're hoping is that we get these establishment of these ICPs, and then those kind of things will be able to be you know, available for patients, you know, no matter where they live. So you know, I'm very optimistic that it's going to be a very positive move.
Good. I'm really glad you're optimistic. That's really helpful and it's really positive. And I you know, I take what you've all mentioned about the data sharing, and the key word here is integration, isn't it? It's not about silos, it's about integrating, which means integrating information sharing as well, to ensure, as Hannah said earlier, you know, it's not a postcode lottery. And as you say, best practice can be highlighted and embedded across the UK, or across England, sorry. This is an England only bill, we mustn't forget that. But it's really important, I think, that as you say, Claire, that it's for across the board, because I suppose bladder and bowel services have historically been seen as Cinderella services, which is an issue. And I suppose my supplementary question would be, do you think this bill can maybe shine a spotlight on your services, if you like, you know, in terms of raising awareness? Because as you said earlier on about, you know, it's the tip of the iceberg, that the patients who actually come forward with bladder or bowel issues, there are many, many more who maybe are just getting the pads, doing things for themselves, but not actually coming forward for treatment and advice and support. I just wondered if you think this bill could help in terms of your sector, if that would help. If I ask maybe Louise first.
Yes, I would hope it would, actually. I think there is a potential for that to happen. I'm not entirely sure, you know, what would be the mechanisms. I mean, there's some comments I'd like to make sort of later on in the process about how you get the patient voice more evident within the system. But I think the idea of the integration, and as you say, shining a spotlight, can only be a good thing. How that then manifests itself, I think, remains to be seen.
Yeah. Hannah, do you have anything you wanted to add to that?
I just think some of the clauses in the bill that, you know, I think could have the potential to make a real difference is some of the stuff around workforce planning, obviously. So, you know, at Coloplast we have nurses who are out there providing services. So I think the piece of workforce planning will be really interesting to see how that comes through. Hospital discharge, I mean, I know myself, having been discharged, sometimes with a plan, sometimes without a plan, and the difference it can make. I think that when you're set up to leave hospital, and that's to go into the place of your choice, depending on your condition, whether that's into rehabilitation first, or whether that's straight into your home or a care home or somewhere else. I think getting that discharge seamless, everything from not waiting for 6 hours for your prescription in hospital after you've got your bags packed and you're ready to go, through to, you know, so that piece, I think these are the little things for me that make a real difference, you know. And that's in terms of what we do, making sure people know about how to get their products, about how to use them, all that kind of stuff. I think it is really important, and for the family and the carer as well. So I think some of the stuff in there around discharge, workforce, are the bits that are going to hopefully make some differences for us.
Absolutely, yes. Claire, do you have any thoughts?
Yeah, I mean, I'd agree with what Hannah and Louise have already said, to be honest. And I think that there's just, there's such a massive undertaking, for us to work at a lot of the services that we need to improve. And like Hannah said, discharge planning, it's such a simple thing to work on, but it, unfortunately, we don't always get it right, and and that's the sadness around it. And if we can address things like that, it will ultimately improve matters. We're facing obviously a huge backlog of work from the last 18 months, and we've got to develop better systems to deal with that, and and also for the future, and for any, God willing, we wouldn't have another pandemic or national or international crisis, but we need to be able to form better services that so we can deal with any kind of future issues, so that we're kind of better prepared, and we've got a more robust system to be able to deal with that. As Louise said, I would hope that this would put our services under the spotlight. It certainly lends itself very well. We've got some very good pathways already, and more that we can develop. So yes, let's hope so.
Yes, absolutely. Now I'm conscious I'm slowing you down here, so I'm going to move on to the third question, because we have two more questions, and then obviously we're opening it up to the floor. So please, if you have questions as we go along, please pop them in the chat box. I know we have some already, because we'll be taking those through a Q&A session at the end. So I'm going to move on to question 3. So the Health and Care Bill would see the establishment of a Health Services Safety Investigations Body, HSSIB. How might this benefit patients, and how might it be improved? And I think this is a really important area. So shall I go to Claire first?
I think this is, obviously this is going to be like independent review of healthcare systems, and looking at all aspects. And I would hope that this is something that would encourage staff to speak up freely, and to not be frightened or resistant to be able to do that, because what we want to do is to change the culture around safety, and to make it everybody's responsibility, and that's the only way really that we can move forward, and learn from things that happen. So I think it should be more looked as something to learn from, rather than a way to blame people that where things may not go as you would hope. And we want to make sure that patients have confidence. It's about building patient confidence about when things don't go quite as you would plan, and that they're kind of ensured that that's being looked at by an independent body, really. So I think that that's a positive thing. Anything that you learn from. I've always been very open to learning from mistakes, because I think that there's such a valuable message in there. So I think it should be a positive thing.
Absolutely. Thank you, Claire. Shall I go to Louise next?
Thank you. Firstly, again, agree with what Claire has just said. It's really important that this body is independent, to provide sort of reassurance to all sides, patients and healthcare professionals, that it is independent and looking for answers and solutions, rather than seeking to identify sort of problems or blame. Really pleased to see that it's been extended to the healthcare sector, to the private sector as well. Not least because, you know, the last few years has seen some shocking cases in the private sector. So I'm really glad it now includes them too. And I am totally supportive of the no blame culture and environment and space within which that it should work. But I was interested to see the mention of the safe space powers, and I'd be quite interested to see how those powers will actually work in practice, because I don't think patients should be kept in the dark about issues that affect them. I'm also unclear, and I don't think there is provision in the bill for patients themselves to be able to refer any incidents to the body. So while there is obviously reference to ensuring that patients are taken into account during the process, I can't see that they're able to refer any incidents themselves. And this is something that might potentially be a source of or a cause of frustration moving forwards. And finally, I'd just like to say that what's really good is that, you know, obviously the body's remit is to promote better standards and share information about good practice to be adopted once, you know, lessons have been learned. But how will the system work to ensure that those lessons are not just disseminated but are actually applied? You know, there needs to be some way of ensuring that the best evidence and practice is adopted across the board and not just in the specific local area affected. So, you know, the body has these powers and it's got this remit, but how is that, you know, how are those lessons going to actually be adopted? Because this means there needs to be mechanisms to support that culture change throughout the system.
No, you're quite right there. And again, it's the so what, you know, the overarching headline looks good, but it's the detail again. How do you actually make it work in practice across England? Yeah, you're quite right. Yes, thank you, Louise. Hannah.
Yeah, sound like a bit of broken record. Agree with my other panellists on much of what they've said. You know, ensuring patient safety is paramount. We are, a bit of brag time, we recently just found out that we've been awarded outstanding by the CQC for our nursing and telehealth service. And I think that, you know, looking at some of the case studies and the people that they've dealt with and continue to help, just shows what an important issue, you know, this is. I think personally, I believe in some of this around, you know, information being a good therapy in itself. So good information, as Louise says, how will it work in practice? So there's something about the good information piece being timely as well. You know, I suppose questions around practically, will it work with PALS? Will PALS feed into it? Is that, you know, like that kind of mechanism in terms of where does, you know, if I have a problem, where do I go? Do I go through PALS? Do I go through this? You know, so I think knowing what the pre-existing, what the landscape is and what will change and what will stay will be important to know from you know, a patient perspective.
Yes, you're quite right. And I think obviously the fact that this is an independent body is very important, but I'm still not clear on the details of who is part of it, how does it work, how overarching is it, how, you know, what level is it at, and you know, these are details again that need to be worked out in secondary legislation, I'm sure. But I think Louise made an important point there about it covers all care providers, so, you know, within the NHS and external as well, and I think that's a really important point. Okay, I'm going to move us on to question 4, and yes, brilliant, thank you. The bill commits to reducing bureaucracy on commissioners and providers, helping to reduce pressure on the NHS. So what impact might this have on the urology sector? This is a big one, obviously bureaucracy, you know, is always a big complaint about the NHS. So I start with Louise.
Oh, right, okay, thank you. Well, I think firstly, I think it's good to see common sense measures to reduce requirement for competitive tendering where it doesn't make sense to have it. So I think that can only be a good thing. Anything that saves, you know, time and effort on something which really shouldn't be spent on that area of things is a good thing. But however, in relation to patient choice and product innovation, I think it actually needs to be easier for new products where they've obviously been proven to work and to be safe, to be actually included on the procurement list as well. And these should not just be driven by cost considerations either. There should be choice for patients within the types and products, treatments available. So, for example, the cheapest products might not always be the most cost effective in the long term. So it's really important that patients have choice and are consulted as to their preferences. There's a lot of anecdotal evidence that there's a real inertia in the system when it comes to selecting alternative products. So even though they may have been proven to be better than existing products, it's, you know, there's an inertia to getting them added on, or there's inertia to ordering them or using them. You know, people default to what they know. And that's really frustrating, I think, for manufacturers and suppliers, but it discourages innovation and new product development. And I think in the end, it's really bad for patient treatment and care. So, you know, great at reducing bureaucracy, but I worry about things like streamlining, if streamlining means that there may end up being less patient choice for products available.
Yes, you don't be throwing the baby out with the bathwater, do you? So that's, yeah, that makes sense. Hannah, as from a patient perspective, obviously you might have some views on this.
Oh yeah, I mean, there's obviously the Coloplast, the patient one, but yeah, I mean, I suppose from the patient bit, if that's the kind of hat I've got on, anything that just makes it easier for me to just crack on, get up in the morning, take my medication, whatever that is, you know, whether it's get my bag on, whether it's going for a swim, like whatever those things are that just makes it easier for me. It sounds really basic, but it's in the kind of area we're working at, that's what we're talking about. We're talking about just making it easier, right? So anything that does that from patient perspective, fantastic. In terms of kind of, as Louise has said around the procurement bit, I mean, I couldn't agree more, Louise, you know, you're spot on that in terms of innovation as well and patient choice. I think the other thing that's important to say in terms of, you know, Coloplast is, you know, we have our nurses, we have our telehealth service as well, and you know, we're very much in the community. So I think anything, again, from acute to community, anything around being able to reduce any form of bureaucracy around that's really important. You know, we've got examples of where our nurses have, you know, again and time again relieved pressure on the NHS. So, you know, that's incredible, you know, plugging gaps, making sure people aren't falling through them, and not just during COVID, but, you know, before that, and we'll kind of continue to do that, and making it as easy as possible for people to do that in their home, whether that's a virtual call or something else. So I think in terms of anything that, you know, allows that care in place of choice, reducing the bureaucracy it can only be a good thing, really.
Yes, I think you're quite right. Thank you, Hannah. That's really good. Claire, your thoughts?
Yeah, I mean, I pick up obviously what Louise said about the procurement, and that's, you know, that's always a difficult one, because it quite often lends itself to just being a money saving exercise. And you know, obviously this is going to allow us potentially to, you know, to reduce some cost over a wider patch, as it were, from a procurement point of view. But it is really, really important that, you know, we have patient perspective on that, and also clinician perspective, because sometimes our worst nightmare is when our procurement department, you know, make a decision without full engagement, and then we end up with a product that's not fit for purpose, and it might be cheaper, but it's not actually in the long term cost effective at all. So, you know, that's, you know, definitely needs some consideration. But, you know, what I would hope in terms of, you know, reducing the bureaucracy is, you know, being able to respond faster to, you know, to the needs of our populations. And, you know, we've seen that, you know, that it can be achieved. We've seen that in the last 18 months, you know, things have changed very, very rapidly. And, you know, that red tape and those blocks to why, you know, previously those things couldn't happen have just been washed away. So, yeah, we want to continue to, you know, to build on that. And, you know, and to look at things like where our high volume, low complexity work can be delivered, and, you know, and that's ultimately going to be of benefit, because it's going to then free up you know, capacity in other areas, so, you know, where we can deliver other services. So, you know, I think that it does have obviously a huge potential to reduce that, and, you know, it will ultimately encourage our greater engagement with other sectors, and with, you know, the voluntary sector, and with charities, and you know, and that also is a very positive thing.
Yes, and I think all three of you made very powerful points about the fact that procurement needs to be slicker and swifter. Obviously evidence-based, you know, you can't just put in a product which hasn't been tested, as Louise said, but once it is there, you know, as you say, it's not always the cheapest, which is the best value for money. And I think, you know, certainly within the urology sector, you all know that, you know, the products are not, you know, you don't use them for a week and then you discontinue it. You know, it's a lifetime commitment to it, and if it's not the right product, then it's you know, it's really distressing for the patient, you know, to try be messing about to get the right one when they know this one is better and it will work for them, you know. Hannah, you know, in the previous meeting you were very clear on that, and it was really good to hear that. So yeah, absolutely. So I'm going to move on to the last question now. For you, but obviously people who are watching, please put any questions you may have in the chat box if there's anything else. So question 5, from your perspective, as a clinician or provider or patient, is there anything you feel has been missed from the Health and Care Bill? So let me start off with Hannah.
Where do I start? No, not at all. I mean, let's be honest, this bit of legislation is one bit of legislation. Obviously it's important, but for a lot of it, it's kind of putting into law, I suppose, what was already in a way sort of starting to happen. So I think I don't want the bill to be, obviously it's important, but I don't want to be seen as a distraction or, as I said earlier, sitting in silos. So some of the stuff for me that I think we should continue to look at is the other bits of legislation that are sitting around this at the moment. So, you know, other bits coming through on prescription age and pension age. There's a recent consultation on that. So, you know, it's about these other bits. I think, you know, stuff coming through on women's health, consultations out on the levelling up, on these other bits of, you know, policy popping up here and there. I think it's important that it's seen holistically of, if we move something over here, what does that mean over here? I mean, really, obviously, it still doesn't cover it, but social care and healthcare integration, like for me, it was, that's the, you know, that's the dream for me, is that integration. And I know, you know, won't go down talking about the route of social care funding that's in the news at the moment, but, you know, that joined up care is the dream, really. And having that budget where it's not being moved from one to another, where actually, again, from a shared decision-making point of view and from putting the patient bang in the centre, sometimes I don't really mind whose budget it comes from, right? I just need what I need. And I know that is like the most immature thing to say, and it's like in dream cuckoo land and all the rest of it, but that's, you know, the integration of those two things is what potentially is still missing from one big old bit of legislation. So yeah, that's it for me.
Yeah, and I don't, and it's not immature, because we're asking you from your patient perspective, you know, and you're quite right. You know, why would you care which budget or which pot the money's coming from? As long as you got your products when you need them, in the right time, right place, what does it matter to you? And that's the way it should be, surely. So yeah, I think you're spot on there. Let me move on to Claire, who's coming at it from a different angle.
Yeah, I mean, I was just thinking from the same perspective as Hannah, really. When you're at the coalface, you don't really care where the money's coming from either. You just want to make sure that you've got, you know, the right equipment and the right means to be able to, you know, to deliver the high quality service that you want to, really. And I think that, you know, it's important to remember that this bill isn't going to, you know, isn't going to make everything right overnight. It's going to be a very, very, you know, long process. It probably won't be right by the time that I retire, you know, but it is very much a drive towards, you know, some kind of systematic change and, you know, that's going to be an ongoing developing things, and we're going to do things, and we're going to set things in motion in one way, and then we're going to reflect on that, and it's going to need to change again, because that's healthcare. It is an ever-changing environment. So I think that it's a good start, it's a good grounding. I see it as a positive thing, but there's an awful lot of work there to do to establish this true collaboration, not a collaboration on paper. It's a collaboration that's got to work in practice. And we've started the process of that in some areas already, and we've just got to build on that. And if we can achieve that, as the way that we want to, then ultimately it should be a very positive thing, and very positive thing for our patients. So,
yeah, you're quite right, and I think you've highlighted a good point there, because people make it work in the NHS. Over my 30 years in the NHS, people were making it work despite what was, what were the rules and regulations. They were like, okay, taking it on board at the cold face at ground level. Okay, how do we get together? How do we collaborate? How do we work together? And I think people in the NHS are brilliant at doing that. That they will overcome difficulties. They will work together to make sure it's the best service possible under the circumstances. So you're quite right, Claire. Yes, Louise.
Yeah, I absolutely support what's been said before. Really welcome the sentiment in this legislation about, integrating and having a more holistic and joined up care centred on patients. You asked what I thought might be missing from the bill, which is, from Hannah's point, there's all the wider aspects of how it all works. But I still get the sense from reading through it that there's sense of patients still being on the receiving end of things, patients and provisions for patients to be consulted on their care. But where are the mechanisms for enabling patients or patient groups to proactively draw attention to aspects of their treatment and care to the Icbs or Icbs? Are there any mechanisms within the bill for them to be able to do so? So this is more than just having a patient representation on an Icb or Icp, but it's actually providing a conduit and a mechanism for proactively investigating patient recommendations. And I think when that happens, because there is talk in the bill about, patients being more aware about, how the systems are supposed to operate. But, how does that actually translate into reality? And not every patient's going to actually want to, have all that knowledge. They just want the care. So that there needs to be a way of making sure that, the patient voice can be heard coming up as well as sort of coming down, I think.
No, I think you're quite right, yes, and I think that's really, really important. So, I mean, this bill, it's got lots of positives, it could be really good, and I think the devil will be in the details. So we will, from a parliamentary point of view, we will be scrutinising it, making sure it's got as much as it can in. But it's people like you, the experts in your fields, in your areas, who can say, oh, don't forget about, and make sure this is included. So it's really, really important you have an input as well. So thank you very much for that. So those are the sort of set questions, if you like. I'm going to move on to the chat box now because, oh, there we are. Move my little box. Hang on. I can't do that. There we are. So any questions in the chat section and your little chat box there. Now we've got some questions in there already. And Timon Colgrove has put in about his actual treatment, if you like, and the fact he went through a private option with proton beam therapy. And he makes the point, this saves the NHS considerable sums of money, yet I had to discover this treatment option myself. So his plea will be, let the NHS speak about and encourage private treatment. So I don't know if maybe if I come to Clare, in terms of options for treatments and things like that, do you have any thoughts on that?
Yeah, I mean, obviously, prostate cancer is my kind of area of specialism, and proton beam therapy is a treatment that's currently not available on the NHS, and obviously that's that's why it's only available as a private treatment. And, you know, we do have some, it's not something that we routinely talk about in terms of options, you know, for treatment of localized prostate cancer, because you know, we look at treatments that are NICE approved and obviously are NHS funded treatments. So yeah, I think moving forward, you know, these kind of treatments, when they are you know, approved by NICE and then they're available, usually they're available in smaller centres, and then as that kind of experience and you know, proven reliability of that treatment, then that means it would be more widely available. But currently it is only available as a private treatment, you know, so at the minute there isn't anything that we would be able to do about that, and I don't think this bill will help that as it stands at the moment.
No, thank you, Claire. I don't know, Hannah, do you want to add anything to that? You don't have to do.
No, not on that bit. I'm just looking at the other questions. Happy to come to.
That's fine, no worries. And Louise, I don't want to leave you out. Is there anything you wanted? That's fine. Okay, I'm going to come on to the next question. And there's one from Suzanne who says, one of the areas we receive lots of complaints about is the poor services for incontinence patients from GPs. And her question is, how will this bill change or improve this area? That's a good question. Let me see, shall I go to Claire first?
Yeah, I mean, I think that, you know, the first important factor here is why is the patient incontinent, and I think that, you know, that has to be established, and you know, once and this is about accessing, as we were talking before about services, you know, around incontinence, which do tend to be the poor relative in a lot of areas, which is, you know, something that desperately does need to change. There are huge waiting lists for patients to be assessed for all aspects of incontinence. So in terms of, usually it's not the GPs that provide the service for incontinence, but usually, you know, the prescriptions for the supply of the aids for incontinence, I think, is probably around that way. But, you know, usually incontinence services are provided by secondary care, although they may be actually, you know, clinics in the community. So we're hoping that obviously this bill will help to improve those services, you know, in localities, so that, you know, that the patients have got a better access to assessment of incontinence.
Sure, no, thank you, Claire. Louise, do you want to add anything to that?
Yeah, I mean, I think Claire's right, but you know, this is one of the things we touched on earlier, that potentially this could be something where the patient voice has a way of, you know, bringing something like this to the attention of the board or the of the partnership, to actually sort of argue about, well, how do we make sure the services are more joined up? And Claire's absolutely right. Of course, you know, GPs diagnose up to some point and they may be able to prescribe one or two things, but actually ongoing management and care is done in the secondary sector. So things like, you know, having a wider variety of products that's available would potentially help. But yeah, I mean, I think this is really where the joined up thinking has got to be able to provide some real sort of visible improvement to people who are suffering from this.
Absolutely, yes. Thank you, Louise. Hannah, do you have anything to add?
Just, I suppose, again, coming back to the bill won't do everything, right? But there are other mechanisms that still have to be looked at for improving, say, some of the pathways, etc. I echo, you know, again, as we said earlier, depending on the reason why somebody is incontinent, I suppose, depends on the service potentially they're going to get, you know, depending whether they come through maybe an MS route and they've got a specialist nurse, or whether they're spinally injured or whatever it might be. I suppose there might be different ways that people kind of come into the pathway of using, say, catheters, etc. And like you say, they're used for a long time generally, and again, so it's making sure that this isn't a one-off piece, but in terms of that services for incontinent patients, I think that, again, coming back to the choice that I heard from somebody the other day, that this is through somebody I met the other day, where she was told that she wasn't appropriate for intermittent self-catheterization with her dexterity. And she said, well, just let me try. And she tried it, and she's made it work, and that's working for her. So I think about that listening bit about, again, it comes back to that shared decision making in the services. Like, I can tell you what I need my life to be like and what I need to do, and I need your clinical expertise and brilliance to match me up with the thing that's going to help me do that best. You know, the NHS is brilliant. Do you know what I mean? It's brilliant, right? And so we're incredibly lucky. But yeah, it is gonna be a case of, in the bill, in those boards bits, coming back to what Louise and Clare have said about how you can find a mechanism to elevate some of those quieter voices, I think, yeah.
Yeah, no, thank you, Hannah, yes. Okay, the last question is from Scarlett, and it says, is it true, as Labour health spokespeople have been arguing, that the bill will permit the privatisation of the NHS by giving the private sector service providers a seat on the Icbs? Now, I'm going to, unless you've got some strong views and you want to say that, I'm just going to say that this bill it has potential for all sorts of things. And obviously, as a politician, sadly, we look for the worst in things. And it's great today you've been looking at the positive aspects and the best in it, which is a really, really positive way of doing it. There are issues there, and I'm sure, you know, we could get into a political argument about this for a long time, but we're not going to do that now. So thank you, Scarlett, for the question. Now, we will take it away with us. But what I want to do now, because I'm going to draw things to a close, and I want to say thank you so much to the panel today for sharing your knowledge and insight, and you know, your thoughts on the new health and care bill. It's really, really useful to have, you know, the perspective of the clinician, the provider, and also the patient. Thank you so much for the enthusiastic way you've approached this. It's been really, really helpful. I found it really useful. I want to thank the audience as well for your participation, for the questions. And I just need to remind you that if you would like more information on the Urology Trade Association, you can always get in touch by emailing uta@whitehousecomms.com. And that would be really helpful. I think perhaps if Imogen can put that in the box, just so people can see how to get hold of that, that would be really useful. But otherwise, I just want to say thank you to everybody for participating today. Thank you for Imogen and Jordan for setting it up and running it so smoothly. And I've really enjoyed it. Thank you so much.
Thank you, Ruth, by the way. Thank you to Louise as well.
Thank you.
Lovely.
Thank you.
Good to see you all.